end, I did give you a summary table with the mechanisms for these things, so that should help you study these drugs. But we will walk through the major points, and obviously if you have any questions, if we don't get through all of it, there is a speaker right after this class in here, but if we don't get through all of it, touch base with me anytime. We can go over it. Again, I list the chapter here in Goodman and Gilman. I never assign chapters, but I did pull the information from there if you want to go back to that. And the only required reading for me on these 2 lectures is that supplementary information that was posted to Blackboard, which is really a summary of what I've gone over. So one thing that's important to remember when we think about therapies to treat dyslipidemia, it depends on what your specific problem is. So I spent the whole last lecture talking about LDL and HDL and VLDL and triglycerides and chylomicrons. Well, the reason for that is we're going to talk about several classes of drugs. They have differing efficacy depending on which component is dysregulated for you or your patient. So we think statins, we talk statins cure everything. Well, actually, statins really don't. So we're going to, when we walk through some of these drug classes, some of them that might not be prescribed as often may actually be more efficacious for statins for certain types of dyslipidemia. Okay, so those are the sort of things that you should be thinking about as you get ready to go into therapeutics. Okay, so I'd like to start out this section with a little taste of therapeutics. Obviously, this is not a therapeutics course, but when we think about patients who have dysregulation of lipid metabolism, we have to think about dietary and lifestyle changes, and you might be counseling patients around this. So, and then the question of when to treat with drug therapy. When is diet and lifestyle not enough? Well, that depends on how well the lifestyle interventions work. Pretty much for any patient who has dyslipidemia, they should be counseled around lifestyle changes. Every patient, okay? But for a lot of patients, that's not going to be enough. And the other piece of this information that I want to touch on again, I mentioned in the last lecture that in November of 2013, so just a little over a year ago, the guidelines about how patients are managed changed dramatically. And that's something that you hopefully are going to be talking more in depth about in therapeutics. And also, again, we touched on genetic predisposition. So there are people that no matter what they do, what they eat, how much they exercise, they're going to have dyslipidemia, and they will always need medication to treat. Pregnant and lactating women. So this group is always complex to treat for various things. You're always worried about the baby. Well, the other side of it as well is that if a woman's lactating, she has to make fat for the milk, okay? So we're talking about lipid metabolism. We need to think about, all right, mom's now having to make a lot of milk fat. Are we going to treat her with certain drugs that we might treat her with if she was not lactating? So that's part of that thought process that when we think about patients. And then there's also kids. So especially in families that have familial hypercholesterolemia, for example, when do you start treating kids? How early? So this managing the benefits and the risk of treatment. Typically in kids, drugs are not indicated prior to age 16, but not always. And we'll talk about one class of drugs that is probably the best tolerated and could be an option for some children. So this is the old table in the book from the previous NCEP guidelines. Although the guidelines have changed of how we treat patients, I think this table is really useful for you to look at about how patients can be screened for LDL, non-HDL cholesterol goals, lifestyle changes, and threshold for drug therapy as a background. This is the article if you want to read it on how things changed. And this is a figure from the article. Again, this is therapeutics. I'm not going to test you on this, but if you want to read this, if you want to get into this before therapeutics, they break out different patient groups and how they should be screened and treated. And this is the group where things are really changing around more aggressive statin therapy. So again, for those of you who want more information, who want to get a jump on things, I have all the references here for you. And finally, I mentioned as part of this new paradigm, there's a risk calculator to determine which group you fall into. If you want to calculate your own risk or your family's risks or your neighbor's risks, here's the link. You can go right to it. So if you want to play around with that, get familiar with it, it's there for you. Okay, so dietary management of dyslipidemia. So pretty much prescribed for everyone that has some form of dyslipidemia. So depending on what you eat, you can impact differently LDL, triglycerides, and VLDL. So LDL, if you eat cholesterol, saturated and trans fats, those will increase LDL. In case of triglycerides, it's total fat, alcohol, and calories. So calories could be sugar, okay? Triglycerides are very sensitive to that. VLDL, sucrose, and fructose. How many of you have heard about the evils of high fructose corn syrup? It increases VLDL. That's why it's uniquely problematic in our diets, okay? So it depends on what you eat as to which one of these components you're going to be screwing around with. So general recommendations for patients with dyslipidemia. Limit total calories, limit saturated fats. This Mediterranean diet, how many of you know about the Mediterranean diet? Ish, okay? So complex carbs, fiber, olive oil, not saturated fats, okay? People who do not have a genetic predisposition to hypercholesterolemia, if they follow these sorts of guidelines, they can reduce cholesterol 10 to 20%. That's significant. That's significant. So these are always good recommendations for patients. Weight reduction, caloric restriction, and avoidance of alcohol. If you have elevated VLDL or IDL, these are especially important. I didn't say LDL, all right? Alcohol, calories, lose weight. If you have primary chylomicronemia, remember you make too many chylomicrons. You remember from last lecture, we don't have drugs to treat that. You have to change it by your diet. And we're talking severe restriction. 10 to 20 grams of fat a day. A day. How many grams in a Snickers bar? 15. That's your total fat intake for a day if you have this. All right? That's a pretty hard way to live. That's how it has to be treated. Okay, because we don't have drugs to treat that. Nutraceutical approaches. What's a nutraceutical? Foods as medicine. So some component of food that has a health benefit that we use as medicine. Very good. Phytosterols. So these are essentially cholesterol molecules from plants. There's a bunch of them. And I mentioned this whatever day I lectured, Friday. But the difference here, animal cholesterol is taken up and it's atherogenic. Dietary phytosterols are not very well absorbed from the small intestine. And if they are, they tend to be shunted back out, okay? So they're not, and they're also not atherogenic. So what is the therapeutic value? Well, there's some data that suggests that they reduce cholesterol absorption from animal products, okay? Data to support. You have to eat a lot of it, about 2 grams a day of this stuff. But there are data that suggest that it can reduce LDL by 10%. Again, that's not insignificant. That's not insignificant. It takes about 2 weeks to see efficacy. There's some data out there that naturally occurring phytosterols are more biologically active than purified ones. But what's important, how many of you have seen a heart healthy label? Heart healthy label? That's an FDA approved label. Did you know that? So a manufacturer can't just slap that onto anything they want. That's an FDA approved label. So it's not a drug, but FDA is saying there is sufficient evidence to suggest there could be a health benefit. So you get to have that label on your food, okay? And these are just, this is probably, these sorts of products are the most popular in terms of that. So there is a nutraceutical approach that for some people, if you eat enough of it, could have some therapeutic benefit. This is a newly approved medication that's a step past a nutraceutical, Vascepa. Okay, so it was approved in 2012. It's the first FDA-approved drug that has EPA in it. Okay, EPA, so we think about omega fatty acids. You've all heard the nutritional, I don't want to use the word hype, but they talk about omega-3 supplements are heart healthy, among other things. How many of you have heard that? Okay, so omega-3 supplements could be considered a nutraceutical, right? Omega-3s come from foods like fatty fishes. They are mixtures of fatty acids. There's thought to be some health benefits. Well, this is the first drug, if you will, that has one of those fatty acids purified out, this EPA, okay? So, clinically proven, their data, reduce triglycerides without increasing LDL. All right, remember, it depends on what you're trying to target here. DHA, which is a component found in most omega-3 supplements, can actually increase LDL, which for most people on a Western diet is not a good thing, all right? So the notion was if you pull EPA out and you purify it and you just take that, you can have efficacy on triglyceride lowering without the detrimental effect of increasing LDL, okay? That's the idea. So, it's approved as adjunct therapy to diet restriction to reduce triglyceride levels with severe hypertriglyceridemia, all right? So that's when you have lots of fat floating around your blood. All right? Interestingly, this drug also is being evaluated for psychiatric and anti-inflammatory properties as well. So kind of an interesting drug. So how does it work? Mechanism of action. It reduces VLDL triglyceride synthesis in the liver and/or reduces the secretion and clearance of triglyceride from those particles. Okay? That's sort of a clinical observation. The specific mechanism is not well defined, but it could include beta oxidation. What's beta oxidation? Beta oxidation, fatty acids. Anybody remember beta oxidation? You should look that up. It has to do with fatty acid metabolism. Inhibition of DGAT, that enzyme that's involved in triglyceride synthesis. Inhibits that, so it inhibits triglyceride synthesis. Leading to reduced hepatic, that's the liver, lipogenesis, synthesis of lipid. Okay? Increased plasma lipoprotein lipase activity. That's the enzyme that cleaves the fatty acids off the triglycerides. It's on the inside of your capillaries. Limitations of use. So remember, patients who have elevated triglycerides are very susceptible to pancreatitis, which can be lethal. So the effects of this drug on pancreatitis has not been determined. All right? Don't know the answer. And we don't have data on cardiac outcomes either, okay? So it's a new drug. It's a first-in-class type of drug. We don't really know about these outcomes. Okay, so that drug was about reducing triglycerides. Statin drugs are the drug of choice to reduce what? I heard something. What does statins reduce? Come on, people. Statins. LDL cholesterol. It is the rate-limiting enzyme. HMG COA reductase is the rate-limiting enzyme in steroid biosynthesis. And statins are the most potent drugs we have to lower LDL cholesterol. And I showed you a graph in the previous lecture that at least up to a point, the more you reduce LDL cholesterol, the more you reduce negative cardiac events. Okay? That's why statins are first-line drug therapy for patients with elevated LDL. Statins do other things. We talked about atherosclerosis. Okay? These effects are thought to be independent of cholesterol lowering. So if you look at the plaques are stabilized, endothelial function in the vessel wall is improved, inhibition of thrombus formation, and anti-inflammatory activity in the vessel wall, because remember, atherosclerosis is an inflammatory disease. Okay? We have a bunch of statins. Here are things that Dr. Taberge may want you to know. If we think about some individual drugs in the class, simvastatin and lovastatin are prodrugs. And you all remember what prodrugs are? I hope. Atorvastatin, fluvastatin, and rosuvastatin are not. They are active as dose. So that's some difference in the class. High first-pass metabolism. How can these be drugs if they have high first-pass metabolism? Typically, we think that's a bad thing, right? Where do these drugs work?
Liver.
In the liver. So it's not a bad thing that the liver extracts most of it, is it? Okay? Most of the absorbed dose is excreted in bile, although some is excreted in the urine. Most of them have a short half-life, although atorvastatin and rosuvastatin have extended half-lives. How do they work? So I already told you they inhibit the rate-limiting enzyme in steroid biosynthesis. They increase LDL receptors. What do LDL receptors do?
Take LDL out of the plasma.
They take LDL out of the plasma, and most of those receptors are found in the liver. And then those cholesterol-independent effects that I just mentioned. So here's a cartoon for those of you who like cartoons. This is a liver cell, a hepatocyte. This is a systemic circulation. And this is just a cartoon showing what we just mentioned, that it reduces cholesterol synthesis. So lower concentrations of cholesterol in the cell impacts the expression of the LDL receptor so it can clear more. Okay, so it's involved in reducing synthesis of cholesterol and also clearing more out of the plasma. And then there are the cardioprotective mechanisms that are independent of cholesterol. Yes, this figure is horrible. I have searched for better figures, and I think I'm going to have to create one, but focus on the words. So the statin effects on the vessel wall are independent of cholesterol lowering. Okay? Anti-inflammatory, antioxidative effects. And most of these effects are thought to be via nitric oxide signaling pathways. nitric oxide stimulants. And I believe we talked about those last semester. But the big important thing here, statins act at the liver to most potently reduce LDL cholesterol, and they act in the vessel wall to reduce atherosclerotic plaque formation and to stabilize those plaques. And those are independent mechanisms. Adverse effects. So a lot of people take these drugs. They work really well for most patients. But FDA in 2012 put some warnings on the label for statin use because we saw in some patients increased type 2 diabetes. And remember, these drugs are first-line therapy for diabetics. So this was very controversial about how do we manage diabetics when we know this, and also an increased incidence of cognitive dysfunction, which is also troubling given the fact that many people who take these drugs are older. Okay? We've known for a while that some patients have liver function problems with statins. Prior to 2012, patients had to be monitored on a regular basis for liver function. Now, the recommendation has been changed. Patients are screened prior to receiving statins, but they are not regularly screened afterwards unless they show symptoms. Okay, so the thinking was the liver injury is relatively rare. Up to 10% of patients suffer from myopathy. It tends to be dose-related, and for some patients, this leads to non-compliance. So this can be a significant problem for statin use. The other thing that is important for you to remember is these drugs can cause DDIs. Now remember, even if we just think about diabetics, so all diabetics are given this drug. How many other drugs are diabetics taking? Multiple, okay? So these drugs are CYP3A4 or 2D6 substrates, or 2D9, I apologize, and they can be CYP inducers, so it can be quite complicated, right? What's a CYP inducer?
It's more active. Speeds it up. It's more active.
Remember this from last semester? Anybody remember this from last semester? Homework, test question, it's back again, okay? So they can induce metabolism by inducing, for example, CYP3A4. So atorvastatin can induce its own metabolism through a nuclear receptor pathway. Remember nuclear receptors, complex up with these things, bind DNA, regulate gene expression. So atorvastatin induces CYP3A4, so it makes more of it, and then is metabolized by it. And a whole bunch of other stuff is metabolized by CYP3A4. So that's why I'm showing you this again. Okay, statins. Now we'll move to niacin, okay? What does niacin have to do with dyslipidemia? Well, it lowers both cholesterol and triglycerides, okay? So it's often used in cases of familial hyperlipidemias. So it can reduce LDL, VLDL, and lipase in most patients, 10 to 20%. Okay, significant efficacy. It is the best therapy we have for increasing HDL. Best therapy we have for increasing HDL, 30 to 40%. A lot of folks have low HDL. We remember HDL is cardioprotective, so that's a good thing. Can reduce triglycerides 35 to 45%. Much better than statins. Much better than statins. So if elevated triglycerides is a problem, this is a better therapy. Can be used in combo with statins and other things. There is a fixed dose combo of lovastatin and long-acting niacin. Adverse effects. How many of you are aware of flushing reactions with some drugs? This is one of them. Okay. It can also cause impaired glucose tolerance and gout, which can be problematic. How does it work? So the niacin has some complex mechanisms of action. It affects multiple tissues in the body. Okay, so this is more complicated than statin. So if we talk about fat cells, if you take a lot of this, so gram quantities, it inhibits lipolysis. So that's where you break the fatty acids off of the glycerol. This is the primary source in your body of circulating fatty acids, which the liver then takes to make triglycerol. So it inhibits this process. Okay? It also binds to a GPCR adipocytes, GPCR 109, which couples through GI, which means it's inhibitory to adenylyl cyclase, and it inhibits hormone-sensitive lipase activity. So this is another enzyme that causes lipid breakdown. In the liver, it inhibits VLDL secretion and increases clearance of VLDL by lipoprotein lipase pathways. It increases HDL cholesterol by reducing the clearance of HDL, ApoA1. Remember, apoproteins, the proteins, the ligands on these particles. There's more. Macrophages. What do macrophages have to do with all of this? Do you remember? Macrophages can turn into foam cells. What are foam cells? Fat. Yeah. And where do they do their dirty work? Atherosclerotic plaques, okay? So macrophages are involved in atherosclerosis. So niacin reverses endothelial dysfunction, so those are the cells in the vessel wall, by reducing thrombosis. So increased secretion of plasminogen activator, reducing plasma fibrinogen, reducing thrombosis. Increasing expression of the scavenger receptor and these cholesterol transporters to get rid of cholesterol instead of depositing it, and reducing cholesterol content in these foam cells. All right, so niacin is hitting multiple parts of this dysregulated pathway. Okay, moving right along. Fibrate drugs, another class of drugs. Here are a couple examples of these drugs. Their efficacy depends on a few factors. First of all, what is your lipid profile to begin with? Do you have a genetic predisposition to hyperlipidemia? Environmental factors such as diet, and quite a bit of variability between drugs in this class. And the mechanism of action of these drugs is a bit complex, and so it's not always easy to predict efficacy. Having said that, they are typically the drug of choice for treating severe hypertriglyceridemia, so elevated triglycerides, and chylomicronemia syndrome coupled with dietary fat restriction. Okay? So, triglycerides and chylomicrons. Increased triglyceride clearance, reduced triglyceride synthesis in the liver, lowers serum VLDL, and increases HDL. Some, but not all patients, you will see an LDL response. This is not a drug to treat LDL. Okay? That's not what these are best suited for. Having said that, this drug is more efficacious than that drug in terms of LDL. So it's not that there's no efficacy, but compared to a statin, these are not as efficacious for LDL lowering. How do they work? So these drugs are ligands for nuclear receptors, okay? So last semester we talked about thiazolidine diones, which act through PPAR gamma. These act through PPAR alpha. It's a cousin of that, which is highly expressed, especially in the liver, okay? And I'll have a slide to show a little bit about that in a minute. These drugs increase fatty acid oxidation, so that's breakdown of fatty acids for fuel, increase the synthesis of lipoprotein lipase, which breaks down triglycerides, reduces ApoC3, which leads to enhanced clearance of VLDL, and increase ApoA1 and ApoA2, which increases HDL, which is good cholesterol. So here's the cartoon. So lipid-lowering drugs, dietary fatty acids, and some pollutants, which we won't talk about today, can enter the cell and bind to PPAR alpha, which complexes with different things, in both cases leading to changes in gene expression. Through this pathway, you have reduced inflammation because you're inhibiting expression of these. Reducing inflammation is really good if you have atherosclerosis or diabetes. Through this pathway, the genes that are expressed increase fatty acid metabolism, lower lipids. Okay? So these drugs act via nuclear receptor pathway. Nuclear receptors affect gene expression. They can make expression go up for things that are involved in fatty acid metabolism, can make expression go down for things which cause inflammation. Okay? Reduced fat, reduced inflammation. Adverse effects, they're pretty well tolerated. GI upset, you may get gallstones, that can be a negative one. Muscle weakness can be seen but not as significant as statins. Should not be used in kids and pregnant women. Bile acid binding resins, different class. These are these gigantic resins. They're insoluble in water. They have been around forever. They're really, really, really safe. Okay? Really, 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 really safe. Basically, what happens is you take these things orally, they're not absorbed, and they bind up cholesterol, for example, so it can't be absorbed. Okay? So the drug itself is not absorbed, so therefore, how do you have toxicity, right? You never actually absorb it. Can be used as secondary treatment with statins to bump up your efficacy. You can have 20% reduction in LDL. So if you never absorb the stuff, it's a great thing. Minimal effects on triglycerides. So they are negatively charged, or they are positively charged. The bile acids are negatively charged. They stick together. That's the simplest answer of what these do. Because you have less cholesterol, that stimulates an increase in LDL receptors. Anytime cholesterol goes down, so you actually clear more. So that's a secondary effect of these drugs. Adverse effects, you might imagine GI upset. You might not absorb fat soluble vitamins as well. And they can interfere with the absorption of other drugs. So again, if we're talking about polypharmacy, this could be an issue. Okay, I think this is the last one. Cholesterol absorption inhibitors. We've talked about if you don't absorb things, that's a good thing. Again, this can reduce LDL about 20%. So we've got multiple drugs now that can have similar range of efficacy. They're synergistic with statins. There are combos on the market by Torrance, one which there are a lot of commercials about. Pretty safe. They don't have the side effects you see in statins. How do they work? They inhibit this intestinal transporter that I talked about last lecture. This transporter that is involved in the uptake of cholesterol from animal sources, okay? So you inhibit that. That's the drug target for these drugs. And here's the cartoon. Here's the apolipoprotein. This is this transporter. So if you block it, it can't come. We got through the whole thing. Here is a table that tries to summarize everything I just said. This is the kind of stuff I want you to know. And again, remember, it depends on what you're trying to change. Is it triglycerides? Is it LDL? Is it HDL? Different drugs target different pathways. Okay? Thank you.